and she's going to talk about the Indian Health Service success story, which is very exciting, and her bio also is in your folder. So, Dr. Mira.
All right, thanks. Thank you. Thank you all. It's nice to be back in Oklahoma, getting familiar with the Samus Auditorium, getting familiar with a lot of the people's faces here. It's really nice. I have my phone here just for timing. I switched it on and I have a text that says, "You were right." I have absolutely no clue where it came from, which area code it's from, but I always that's the kind of text I like to get. So, thank you all for coming today. It's very exciting that we have this new aspect with the disparities workshop. Thanks, Cami, for your great talk there. So I'm here to talk to you about the Indian Health Service. I have a sort of, it's interesting what Cami was saying about WIC. I have a sort of love-hate relationship with the Indian Health Service, so it's mostly love. I really have enjoyed working for the Indian Health Service, and I've been on a contract with them for I thought I was a consultant, but I'm not, I'm a contractor. And I was a contractor with the Indian Health Service for 2.5 years, and working with them on Baby Friendly, and right now I just got a new contract with the Billings area in Montana. My husband's like, Montana? What, you're going to be living in Montana? But it's a work contract with Montana, so I'm back in the Indian Health Service, and I really enjoy working with them. So I'm going to talk to you a little bit about some of the work that we've been doing there over the last few years. So it's been a really long road, and it's a lot of long roads. This particular long road is from the Hopi through the Navajo Nation out in Arizona. And we've been, on the long road, this is the road at the CDC. All these are very different roads and pathways. But with everything in Indian Health, it seems to me there's always a story, there's a why behind it. And my own personal why as to why I became involved with the Indian Health Service in this particular area of breastfeeding and healthcare was that about 7 years ago, I went down the Grand Canyon with my husband and 2 of my boys. We didn't go down the bit where the mules go. We went down the bit where the Indian village is at the bottom, which is very, very different than going down on the mules. We hiked down and we came back on these horses with, as you can see, no helmet and a 15-year-old guide and wooden stirrups. A very exciting and interesting experience. But when we got down to the bottom, which is about an 8-mile walk in very, very hot weather, the first people I saw, I thought there was something wrong, like that people had, actually what I thought was that there was kidney disease because people's faces were so swollen. And then as we spent time in the village, I realized that I think I saw one adult that was not obese the entire time we were there, and maybe 3 or 4 children. The entire population was so obese. And there was no healthcare facility except the small clinic down there. And I just found myself as a healthcare person thinking, how do these people cope down here? And then obviously I knew this is going to lead to diabetes, and I hadn't really done all that much research. I wasn't familiar with the data, but when I realized how the extent of obesity and diabetes in that particular village, and actually even since working with other reservations, I've never seen that level of obesity. And I thought, well, breastfeeding can help this. And what am I doing, teaching breastfeeding to people who, this is the kind of field that I need to work in to have the biggest impact. And that's why personally I got involved, because I just felt that breastfeeding, if we promoted breastfeeding in that community, that would be the one community in the country that I suddenly thought this may have the biggest impact, per person than it does in any other community. And that was the why. And then, I just think we're up against it when we talk about small communities and small nations versus the McDonald's of the world. And this just was a picture I took when I went to the Hopi Reservation, right at the entrance of the Hopi Reservation. Welcome to Hopi lands, and it's right underneath the McDonald's. Compared to my breastfeeding friends out on Navajo who have their breast milk good start up on the Hogan there, and it's just very, very difficult to compete with people, with companies like McDonald's that target populations where they're going to sell a lot of very unhealthy food very quickly. So I always am in favor of the underdog. So I just think, oh, good, I'll fight against McDonald's. And then the other thing that I have to say, and this is just claiming a link, which there isn't really a link, but it's just an interesting sort of parallel. The top part of this picture, those 2 pictures are of Gallup Indian Medical Center. And the bottom picture is my hospital in my hometown of Huddersfield. And, actually when I got to Gallup, I was like, oh my God, this hospital looks just like my hospital in Huddersfield. And I come from a country where we have a national health service that's free to everybody. And there's no peculiar concept that single payer is not good or something. It's that's what people deserve, a system, a healthcare system that takes care of everybody for free. And that's, the Indian Health Service is actually a healthcare system that takes care of its patients for free. And I think that's what we should be doing with healthcare in this country. So that is the other reason that I find it something I can relate to in terms of being a system with a budget and those difficult decisions to make, and it's very much the same kind of thing as in England where we have a budget and we have to budget for healthcare. We don't just keep on spending and spending and spending and spending. So I think most of you are familiar with the Baby Friendly Hospital Initiative, that it was launched back in 1991, and it's a designation that is given to individual hospitals to show that they have met the 10 steps to successful breastfeeding, which is the tenet of this. And if you don't know about it, then just go read it, because everyone else would be bored if I read the 10 steps. But if you just look at the yellow words, you need policy, you need training, you need to deal with prenatal care and pregnant women. You need to help breastfeeding quickly, show women how to deal with separation from their babies. They should have only breastfeeding. Babies should be rooming in, feeding on demand, don't have artificial nipples, and people should be referred to the community when they go home. So the Indian Health Service actually, to give them great credit, they have taken this more seriously than many other organisations in this country. And they had been doing some breastfeeding work before Michelle Obama came in and decided that everyone was going to become baby friendly. So they had done some groundwork. They were promoting it as a best practice for diabetes prevention. And Michelle Obama has the Let's Move movement, which is to try and reduce obesity in general. And she had Let's Move Indian Country, which is a sort of split of that, and that's the trying to reduce obesity in Indian Country. And in 2011, Michelle Obama decided that all the 13 federally operated Indian Health Service hospitals would become baby-friendly. I'm not sure how many of you recognise that. Not all of the Indian Health Service hospitals are federal. So, for example, the Cherokee, Chickasaw and Choctaw in your state, they are Indian Health Service, but the money goes direct to them from the government, bypasses the system. And then Claremore is a federal site. So I'm talking today about the federal sites, because that's the ones that had the mandate. The government, the IHS cannot mandate that tribal hospitals do things. So the mandate was for the 13 federally operated sites, but the 638 sites, which is that's the opt-out for the tribal sites, were encouraged to become baby-friendly as well, although they couldn't tell them to be. So when I started working with IHS, we took a look at what's in our favour. Well, in our favour is that we're not like this at the Indian Health Service. So, a lot of places are coming from a culture of very sort of strict, white, religious, I assume this is Catholic based on the nuns, sort of backgrounds in the hospitals where moms and babies were separated. So this is a nursery in an old-fashioned non-Indian hospital. And you can see that. Oh, no, that's not right. Hang on. Was it the red button that makes it? Yeah. Okay, hang on. So you can see that this thing here, this is when they used to keep all the babies in the nurseries, and this was quite standard in many hospitals around the country. And then they put the babies in these kind of trolleys and took them up to their moms once a day, and then brought them all back to the nursery where they were cared for by these very strict-looking people in the nursery. So one of the great things is that the Indian Health Service didn't actually have to deal with this kind of history at all. And they were already some things that really in place there that were helpful to this. So this is an IHS facility. This is Chinle out in Arizona. And this is the thing that I thought was really interesting when I went there the first time. This is actually a loop to put the birthing belt through. And also at Chinle is this picture of childbirth that's done, traditionally Navajo childbirth. And this is the birthing belt. So in the hospital at Chinle, they have brought that into the hospital so women can bring a belt in and use the belt if they want while they're giving birth. So there's more of it, and this picture actually is taken from the wall of Chinle Hospital. They have this big mural there. So there's definitely a link to more traditional practices that perhaps is different than the traditional hospital practices that many of the other hospitals in this country have been had to come away from. if they're going to be baby friendly. So Indian Health Service launched the Baby Friendly Initiative in 2011. And this is Dr. Susan Carroll doing the launch at Shiprock in New Mexico. And they had an initial train-the-trainer meeting for people from all over the country. And right off the bat, it was a really good plan because they brought everyone together at this one meeting and did train the trainer, and everyone sort of met each other from all the different federal sites. So kind of the progression of what happened at the Indian Health Service, the first 3 hospitals, which are in the Dakotas, set the stage really, and they had Clifton Keenan, who was speaking here last year at your summit. And Clifton really took those 3 hospitals, which were in what we now call the Great Plains area of the Indian Health Service, and he really ran with it. And he made those 3 hospitals baby friendly fairly quickly, within about a year and a half, lots of intensive work. But it was really kind of his energy that did it. I mean, there's always energy behind it. I mean, he implemented it across the system and people took it on, and it's now, you know, ingrained in the system. But it was really led by Clifton. And he was kind of isolated up there in the Dakotas. So the rest of the system really didn't do very much with it. So there we are 2 years later, and like, well, Clifton's hospitals are about to be designated, but what about the other 10? And so the Division of Nursing at headquarters was kind of gifted with this project, and thanks to the CDC, they got some money to hire me as well. So we took a look at this and said, okay, we have to implement this now much more broadly. We can't just do this in these 3 hospitals. How are we going to do that? And I think in your packets you have my editorial about the Indian Health Service, and you don't have to read it right now. But I just want to point out that this was something that was done at very many levels. And people often say, oh, well, you know, they're all little hospitals, or there's not that many people to train, or they were told to do this by the government, so that's why it was easy for them. I'm telling you, it was not easy. Okay, and there were places like, these places are really long way out and they won't pick the phone up. It's a really long way to get to Crown Point. Like, it's like a long way from the airport and it's a long way from the freeway, and you actually have to decide as a system, you're going to invest time in this. So yes, it was somewhat top down, but that meant that the CEO and the CMO of the whole Indian Health Service and the head of nursing were coming out to these tiny little hospitals and paying for me to go with them, and basically showing up at the door and saying, become baby friendly. Now, that is top down, but which hospital systems in the country is investing that kind of investment from their senior leadership? I mean, if all our hospital systems started to do it with that kind of, we are going to do this, then you would have a huge help. So yes, it was top down, but it was top down through a huge amount of investment of time and energy initiatives from those top people. So it was, you know, because I was hired and I'm like, oh God, we have to do this. And I found out like a year later, people were saying things like, well, you know, they're telling us to do this stuff all the time and we don't actually do a lot of these things. And I'm like, oh, I just thought you had to do it. And they're like, well, no, there's all of these things come down the pike and we don't do all of them. So this was one that was taken on and done like that. So some of the things that we did, we trained across the system. And the baby friendly requires training just for the people who work with moms in the labour and delivery and postpartum. But the Indian Health Service went broader than that, and they made in many facilities, they told all the nurses in all the hospitals to do the 15-hour training. Not every single nurse in every single hospital did it, but several hospitals, every single nurse in the hospital did the training of 15 hours. And the same thing for their doctors. They told all their doctors to do it, and most of the doctors did it. It was much, much broader than the requirement for baby friendly. And then they actually created a separate 5-hour course for their community nurses, the public health nurses. That's now available as a course on lactation and education resources. But that was actually created for the Indian Health Service's public health nurses because they wanted them to have additional education in the community. So they took 20 hours, and now they're working to train their pharmacists as well. So they also adapted, so they did a huge amount of training. You know, it was interesting to me, it's a government hospital and people are told to do training and they kind of do it. Like a lot of other hospitals I work with, there's a lot of resistance. They have to pay staff time to train, and they don't want to pay staff time to train, so it's a big problem to do the training. But I have to say it wasn't such a big problem at the Indian Health Service. There was only one hospital where we actually heard, oh, we don't have to do time to do the training. Everyone else just did their training. Some of the other strategies, they also was really beneficial for them to have a system because Clifton actually wrote a policy for the Dakotas, and then that policy was adopted by all the other hospitals with some adaptations, but basically it was available online and it was adapted. So we had a common policy. Again, something that you can do in your Integris system or in your other hospital systems. I mean, I think one of the best ways to go is through a system to try and change all the hospitals in your system at once. So you can have that. We also had like medical record templates that we standardized through the system. That wasn't as easy. And it's also funny, you know, some of these small hospitals go in and alter the template, and I know you can't do that in a hospital with like 8,000 births necessarily, but, you know, we did change the template so that they became baby-friendly compatible. And then there was this great sort of common feeling of like we've got a great common goal here, and as we developed the webinars and as we spent time with people and people from different sites got to know each other, and at the beginning there were, you know, very little comment on the webinars. I mean, my experience when I'm working with privileged white women from the East Coast is that you can't get a word in edgeways when you do a webinar because they all want to talk all the time. And when I was working with the Native American communities, like no one said a word the first 3 webinars. I was like, oh my goodness, what am I doing here? But, you know, as people developed these relationships between the different hospitals, it became much more them presenting the webinars than me presenting the webinars, and that was really fun. And then some of the groups, like this is the Navajo area, they did a baby-friendly task force that spanned the area and also included their tribal sites. It wasn't just the federal sites. So they met regularly. And Jeanette, I have to give credit, Jeanette Yazzie here, a good friend of mine now, she ran this task force, you know, through thick and thin, when there was no hope at the beginning, and then with gathering momentum towards the end. So it was really great to see a task force like that. And then just to sort of talk of some of the strategies that was used, the Claremore, you guys, I don't know if there's anyone here from Claremore today. Usually you're here. Maybe they'll be here tomorrow. But they, you know, some of the things that the hospitals did, for example, they bought or found smaller scales so that they could do rooming in and use the scales in the rooms. And I think Claremore were very clever. They actually switched they found a big old scale that they were using was too big, but they managed to switch it with the pediatric clinic, who were very happy to have a big scale, and they got a little scale. So just some resourceful types of things. When we were at Chinle, this is them closing the nursery. They decided it was just too much hassle to try and do this rooming in and have people still accessing the nursery. So they're just like, okay, we're just going to turn the lights off and close the nursery right here. And they did. That was a great thing they did there. And then this is kind of, I think, my favorite. The skin-to-skin posters area. When I go around all the different hospitals in this country, I mean, God, I go to some of these massive hospitals, they look like cruise ships to me. I mean, they're just these sort of massive, wealthy places, and I kind of wonder why does a foundation have to pay me to come and help you be baby-friendly? But anyway, you know, surely you've got the resources to do this yourself. But anyway, but I do hear that, you know, we can't do skin-to-skin in the operating room because it's too hot, it's too cold, it's too big, it's too small, there are too many people, there are not enough people, the mothers don't want it, the mothers won't, there's a million excuses. Okay, guys, if they can do this at Phoenix Indian Medical Center, you can do it in your cruise ship hospital, because this is not a big operating theatre, right? This is a little operating theatre. They have a lot of obese women. But that's another thing I hear, oh, well, they're obese, we can't fit the baby or some garbage. I mean, they can do this in the operating theatre, in the Indian health system. I think it helps, and I maybe shouldn't say this, I'm being recorded, but I know that a very senior medical officer at the Indian Health Service, well, I haven't mentioned a name and I'm not going to, but a very senior member of this team did have a cesarean baby and did several telephone calls direct with hospitals saying, this is something you can do. You can, you know, would not hear no from the surgeons. So it wasn't like we did it easily, but they did it. They did it, and they did it with very low resources. And I always say skin-to-skin is a big game changer. And once you start that, we were at Chickasaw yesterday. They have perfect skin-to-skin. Yay, Chickasaw. They have a brilliant program there. Anyone that needs to find out about how to do skin-to-skin, go to Chickasaw, because they are doing it perfectly. They're doing it better than most of the hospitals in this country. 1 hour uninterrupted skin-to-skin postpartum, and that's what they do. And so you should do that. It's a very colourful story. We've been to a lot of really interesting places for me as an outsider, going to some really cool places. I like this picture. I loved Zuni. I had a great time at Zuni. Very small community, small hospital. This building here, anyone like to guess what this entire, you can probably see it, this entire building here is their diabetes treatment centre. It's bigger than the hospital, actually. It's bigger than the hospital. They have huge end-of-life care. It's really kind of depressing. It's really not great. The hospital is absolutely beautiful. It's like a birthing centre. I would have my baby there any day. They have 3 or 4 rooms, and it's just like a small community birthing centre. And they do send their high-risk and cesareans to a different hospital, but it's a beautiful place. This is the Pueblo of Zuni, and this is my friend, one of the public health nurses there. And they have great integrated programs. So I think one of the areas that we often fall down on with Baby Friendly is step 10, the community integration, which is part of the problem, that we don't support women when they go home. And I think one of the great things of the Indian Health Service is they do have public health nurses, community members, who go still to the community. Like when I was a kid, the doctor actually used to come to your home. I mean, this was part of National Health Service. If you were really sick, they didn't want you taking chicken pox to the doctor's office, they would come. I remember the doctor coming to my home to see me as a child. In fact, one of my own kids, the doctor came when I was in England one time, actually Scotland, let me give them credit, to the house, and that's only like 20 years ago. So people do house calls, and they do the actual system. We're not relying on WIC peer counsellors necessarily. We've got public health nurses in the Indian health system that go out there and see people in the community, high-risk community people. I just like this picture because just as a sightseer, it just sort of summarizes to me some of the stuff that's really interesting in the communities. There's the church, there's the basketball hoop, and there's the American flag, and then the outdoor oven. And I just think it's just such a sort of mixture of different cultural things that are going on. This is, again, Zuni. Zuni has also, in addition to their great public health nurses, they have a brilliant WIC office. This is the WIC office itself, and this is when you look out of the WIC office across the street, that's the view that you see. And I walked into the community, the WIC office, and this lady came out and she said, "Hello, my name is Ruby Wolf, and I'm here to put the infant formula industry out of business." And that was her introduction. And I'm like, okay, good, this is great. This little tiny office, and they have this level of hope and enthusiasm, and that's what she said. That was the first thing she said to me. I shall never forget it. And I just took some pictures of the really great stuff that they were doing. And so they do work very closely with the public health nurses in the community. And I know some of your I see Fumia sitting here, and some of your own tribal WIC programs are really well integrated with the Cherokee WIC and the Cherokee Hospital. You have great integration with the community in some of these Native American hospitals. And then this is, they did have also WIC peer counsellors. These are 2 young Zuni ladies. None of this was set up. They just walked into the office with me. They didn't tell them that I was coming, and they just said that. Actually, it was Mona from the hospital. She's like, "Please come and see our WIC office. They're so great." I'm like, "Yeah, I'll come." And they were just setting off. They had all these goodie bags, and they were off out into the community to work with moms. So it was really cool. And then actually at the Zuni Museum, they had this really nice display of cultural traditions. And this is the corn blessing ceremony, which is a very important one. And then this is the baby naming ceremony. And you can see here in the corner is a young lady breastfeeding. So it just sort of shows the importance of it as something that's always been done in the community and just part of the normal procedure. It's funny because Mona hadn't noticed this picture. I was like, "Oh my God, they're breastfeeding in your museum." And she's like, "Really? I hadn't even seen that before." So sometimes you see these things from the outside perspective. And then, your hospital here, Cherokee, yay. Cherokee's really, really close to becoming baby friendly. Right, Carrie? And, they are one of the best hospitals I have seen, guys. They are one of the most on-track hospitals. I just knew when we walked in the door that first time when I saw Carrie's extremely well-organized notice board there that this hospital was going to make it. These guys were really on track. They have their big 4D pathway up on the wall, and they have this, and I'm sure now this baby must be nearly at the top of the picture, right? But they have this little cute baby that they kind of move around, which must be right here now, right? You've just had your readiness interview, and they're waiting for their on-site assessment. But, creativity is really cool when you see these things. So well done, you guys, because you've been promoting this stuff in Cherokee for a while. And Becky and I were out there not long ago, and we took some of these pictures. Even in the elevator, they have breastfeeding stuff at Cherokee. And they've forced their physicians to become great advocates. So this is what happened. The CEO of Cherokee writes this beautiful letter embossed, it's like a wedding invitation, hand delivered it to every doctor. And then I just love this, and I show this slide all over the place. I hope the doctor will forgive me. But you know, whether they like it or not, all their doctors are breastfeeding advocates because they made them these beautiful coats that have this breastfeeding mom on the sleeve. So whoever they see, they're going to be a breastfeeding advocate for them. So that's really cool. As you know, Claremore's your first baby-friendly hospital here. It's great that you now have another one. So good for you, Integris Baptist. But yes, we had the delight of Claremore being awarded the first baby-friendly hospital in the state. And we're trying to share this. We had a nice conference in Albuquerque that Cami spoke at a couple of years ago. We're having another one in 2016. So lots of stuff going on with Indian Health. So where are we? What was the outcome of this? So in December 2014, all of the Indian Health Service federal sites became baby-friendly, 100% of them. And that is compared to 6% of hospitals nationally. The first baby-friendly hospitals in Arizona, New Mexico, North Dakota, Oklahoma, and South Dakota were all Indian Health Service hospitals. In fact, 6% of all the baby-friendly hospitals in this country are Indian Health Service hospitals. And just to push the data further, in the 6 states where they exist, where there are Indian Health Service hospitals, 76% of all the baby-friendly hospitals in those states are Indian Health Service hospitals. So they have really taken on the Midwest in particular, and 4 of the 5 tribal hospitals are very well on the way to becoming baby-friendly. And I know you've got a little competition going on here, but there are 2 sites out in the West, which is Tuba City and what used to be Fort Defiance and is now Sahutse Hospital. They're both well on their way to being baby-friendly designated. Cherokee's well on their way. Chickasaw's well on their way. Choctaw needs to get with the program because they're the only hospital. I don't know if there's anyone here from Choctaw. You do not need to identify yourselves if there are, but they're the only hospital in the lower 48 states from Indian Health that is not in the system. The Alaska hospitals have a rule unto themselves and they haven't got there yet, but we're working on them. So yeah. You guys are really, the Indian Health Service is really doing a great job. And this is where they are. So you can see that these are the other baby-friendly hospitals. There's a little bit out of date, this map. There's more of them now, but they're still in the same kinds of places. So most of them are on the West Coast and the East Coast, and we have to add the Oklahoma new one. But you can see that the Indian Health hospitals are really in places where there are not any other hardly any other baby-friendly hospitals. So they've really taken on areas of the country. So some of the barriers at Indian Health to the initiative, one was, it's just one more initiative that we've always been told to do this stuff by the government, we're not going to do this. High staff turnover and understaffing. A lot of these places are very remote and there are not that many staff there, and when they are, they get stressed out and they move on. Top-down mandate has some advantages and some disadvantages. People don't like being told what to do, so there was some resistance right from the get-go. And resistance to change, just like there would be anywhere else with new practices like skin-to-skin and cesarean. Challenges with prenatal education, which is the same all over the place, is really problematic very often. And then charting was always a problem and was there too. So there were some barriers that were indigenous to that particular system, and there were some barriers that we all share, depending where we are. Some of the strengths or the easier parts of it for Indian Health are ethical stuff. Because they're the government, they're supposed to pay for their formula. And any of the federal sites that weren't paying got paying real fast because they were really supposed to be paying. And like WIC pays for their formula, they buy it. They give it to women, but they do purchase it because they're a government agency. And the same thing as this, Indian Health Service is supposed to be purchasing their formula. So they pretty quickly started purchasing their formula. Most of them were actually already purchasing it. There were smaller hospitals, so there were fewer people to convince. They were difficult to convince, but there weren't quite as many as there are in some places. Great system-wide sense of sharing of resources and just general pride in the system. And then there was peer pressure, you know, just like every other hospital, they all said, well, the lights are not good enough, we can't do the exam in the room, it's too small in the emergency room, we don't have enough doctors, But once we actually gotten half the hospitals baby-friendly, like out of the 13 or 6 or 7 baby-friendly hospitals, it became increasingly difficult for any of the other hospitals to say they couldn't do it, because we said, well, what about, you know, what about Chinley? They did it. What about, you know, so it was very difficult for anybody to stand up and say we can't do it in this hospital, because the other half of the system had already gone baby-friendly. Some of the benefits, I hope you guys who are in these pictures will agree with me. I think from my perspective, you know, when I started doing this, there were a lot of really great people out there that were really jaded and like, this isn't, you know, we're always being told to do this, and they just tell us to do stuff. But they were really good, capable people, and I think once we got the momentum going, a lot of people, leaders emerged at the hospitals, and I've seen that with you guys at Chickasaw and Cherokee, and across the country, there's been people that have emerged and led this initiative and really themselves gained a lot for it, and gained a lot from their hospitals. You know, it's like, I remember when Becky and I went to that big pink hospital somewhere, and we said, oh, Claremore down the road just got baby-friendly. They're like, Claremore? Like, the Indian hospital? Like, yeah. And that was replicated everywhere, and the Shiprock became baby-friendly, and there was a hospital down the road that had 7 lactation consultants, and Shiprock had 1, and they were like, oh, how could you possibly become baby-friendly, and we can't? You know, so there was definitely a sense of pride, and we can do this. And these are the initiation rates for breastfeeding, and you know, we still have a great deal of work to do. And I do want to point out that this data are only up to 2011, so we can't say that the Indian Health Service baby-friendly has made a difference, but I think the emphasis on baby-friendly is making a difference. The emphasis that Indian Health Service is putting on breastfeeding is making a difference. This is going up. This gap is closing here. This is the Native American population breastfeeding initiation over time. And we're closing a gap here. And I think we can say that the Indian Health Service and the hospitals have got something to do with this. I feel that that initial initiation is definitely hospital-based, right? And now I love this. Now this is like, you know, okay, I can't base too much on this, but if this is the CDC's data, and this red line is Native American exclusive breastfeeding at 3 months, if you look at any breastfeeding at 6 months, it doesn't look like this. So I kind of cheated because I picked something where it looked good. But this is not completely atypical. I mean, you can go, the CDC has like four different data sets, or 4 different, two of them are just boring and the same as they were before, and 2 of them are showing a big change, and this is the one that's showing the biggest change. So you can see that exclusive breastfeeding among Native Americans at 3 months has really, really gone up since 2009. It's not a very big group of people because there's not much representation when they phone them. And again, that's actually another issue to do with minorities. You always have smaller representation when you do big surveys, and therefore the data are less reliable for the minority communities because you don't ask as many people. So it could go up and down much easier, because if you're asking 50 people here and 5,000 people here, you're going to have a lot more consistency with your overall trends. But this is definitely doing something. If we're going the other way, we'd be getting blamed for it. So we may as well take the credit, right? It's going one way, and something's changing in the system. So let's keep following the data, and let's see if it makes a difference. Some of the lessons learned, I think one thing was really nice was that it was embraced by all of the tribal communities. There was a sense, you know, people were coming up and saying, thank you, IHS, for doing this, because Skin to Skin, for example, the CEO at Crown Point said, thank you guys for coming here and teaching us about this. We did know about this. We've kind of been doing this forever, but we really need our young people to do this again. So that was kind of, it was, a lot of it was embraced by the tribes that were working with the hospitals. And I'm only speaking really from the hospital perspective. I worked in the hospitals, not in the community so much. So that was something that was really nice. And this is one of my favorite. We came up with this idea when we were at Crown Point. There was a native healer, and he was talking about how everything happened in the Hugan. And we're like, well, rooming in, like, everything in the same place. So we actually put this together for our Navajo Nation hospitals, and they all have a picture of this up. But, you know, it was just like a nice thing that, like, well, that's what Navajo do, you know, so why not just sort of play into that and show them that they've been doing this forever. So we're only coming back really and teaching you about things that we think you should do, but you've really been doing it forever. You were right in the first place. Let's just try and get back to where you were to begin with. So, as I say, it's been a really long road, and I just want to end with a couple of things. I totally support and feel that what Cami is saying is completely right, and also, actually, I think it's only the tip of the iceberg. I think that stuff goes a lot deeper than that, and that there's a lot of institutionalized racism going on all over the place, and this to me shows one glaring example of this, which is that, Medicare, you're going to spend a lot of money on those people because they're sick to begin with, but this is what the average healthcare dollars is spent on a veteran. This is the average healthcare dollars spent on Medicaid per year. So if you're on Medicaid, we spend about $6,500 per year on you. This is the federal employee health benefits, about $4,500. The Indian Health Service has $2,400 per person per year to spend on its very sick patients. We have a huge burden of disease, and yet the amount of money that is allocated per patient is very, very low. And this is an ongoing governmental lack of investment in the community in that race. So despite all this, the Indian Health Service managed to become baby friendly across the board. I hope I've convinced you it was not easy. It was not something that was just made to happen. They went through the same struggles as everybody else does. And some of these places are not only dealing with the burden of regular disease, but in this particular community in Montana, there's a huge illicit drug use problem, most of it which is originally iatrogenic, because most of it is prescription drug abuse from opiates, from having given opiates to lots of people for a very long time, and now, goodness me, they're all addicted. And that, of course, is true across many communities, but they have a very high rate of that in this particular community up in Montana. And in Montana, life expectancy is 20 years shorter for Native Americans than it is for white people. And in the Dakotas, life expectancy for Native Americans was 59. So this is something that has not been resolved. And yet, if the Indian Health Service can do this, I'm telling you guys in these cruise ship hospitals that you can do this. There's no excuse. If you've got money and resources, you can do this. If the Indian Health Service can do it, anyone can do it. So please take that message back to your hospitals. Thank you.